Quinsy. Middle English. From Old French Quinsy, from Medieval Latin quinencia, from Greek kunonk, canine quinsy, from kun, dog, plus ankine, throttle. Choking cry when a dog is throttled. Paratonsillar abscess. The most common complication of acute tonsillitis is PTA, or quinsy. This is a collection of pus between the tonsil capsule and the superior pharyngeal constrictor. The causative organism is usually beta hemolytic streptococcus, although anaerobic organisms are quite common, especially in the presence of periodontal disease. PTAs are rare in children. They are almost always unilateral. A PTA presents on a background of acute tonsillitis that instead of resolving becomes worse. Patients complain of worsening sore throat, dysphagia and drooling of saliva. The symptoms lateralize to one side, and patients may complain of referred otalgia. On examination, the patient will be unwell and may be dehydrated. The patient will usually have trismus caused by spasm of the medial pterygoid muscle due to contact with pus, as well as unilateral cervical lymphadenopathy. Intraoral examination may be difficult as a result of trismus. Presence or absence of periodontal disease should be noted. The tonsils will look relatively normal, but the tonsil on the side of the PTA will be displaced inferomedially with a swelling lateral to the tonsil involving the soft palate. Flexible nasal endoscopy is usually normal. The differential diagnosis of a PTA may include infective disorders, such as a dental abscess, or non-infective disorders. These are rare but important, and will be determined by a careful history, with an absence of preceding tonsillitis and a longer history of progressive symptoms. Important differential diagnoses include lymphoma and squamous cell carcinoma, deep lobe parotid tumors and carotid artery aneurysms. Left untreated, many PTAs resolve spontaneously by discharging into the mouth, but they may develop into a parapharyngeal abscess. Special investigations are usually unnecessary. Curative treatment is achieved by incision and drainage. This is usually performed under local anesthesia using a 5 ml syringe and white needle, aspirating pus which is usually sent for microbiological analysis. Some ear, nose and throat and surgeons advocate incision of the abscess with a scalpel, and this is good practice in PTAs that rapidly recur. Occasionally, tonsillectomy in the acute situation will be required for persistent PTAs that fail to settle after repeated aspiration. Patients are generally admitted to hospital for intravenous fluids and antibiotics. Some may be well enough following aspiration to be discharged, having been prescribed a single dose of intravenous corticosteroid and antibiotic. Rare complications of paratonsillar abscess include parapharyngeal abscess, retropharyngeal abscess, laryngeal edema leading to airway compromise, rarely pneumonia or lung abscess following aspiration of a ruptured abscess, sepsis,